Hi, everyone. Welcome today to kind of the next chapter in our COVID-19 story and webinar series. Great to see so many people joining us here this afternoon, December 20th, 2021. I'm Kristen Uhlenbrock. I'm the director at the Institute for Science and Policy at the Denver Museum of Nature and Science. I want to give a huge acknowledgement and thanks to, of course, my colleagues at the Institute and the museum, as well as a special recognition to our partners at the Colorado School of Public Health, including Dr. John Samet, who've been with us since the beginning of this series that we started back in early 2020. Today, we are in for a treat. We have two great guests joining us today. We're going to hear a little bit about an update of where we are in Colorado, the status of COVID-19 happening in the state, a little bit about what we know about Omicron thus far. And then for the latter half of the program, we're going to a discussion and reflection, both about this pandemic as well as the health inequities in our society. And we are joined by the author of the new book, The Contagion Next Time. So just one quick housekeeping note for all of our guests who have joined us here on Zoom. Welcome, hi. I'm sure many of you are familiar with how we run this by now, but our chat feature is where you can ask questions, share your thoughts, say hi to me if you want in there. Encourage you to go ahead and open that chat. Maybe let us know where you're watching from, but use that feature to ask questions throughout today. I'll do my best to try to incorporate as many questions as possible into our discussion. A big apologies in advance if we don't get to your questions, but I'm sure many of you are curious and will hopefully continue to find that research and answer if you have a question that doesn't get answered. If you're joining us on one of our other platforms, hello and welcome over there as well. So thank you for joining us today. I'm going to jump right in because we have a full agenda and we have an hour and we're going to cover a lot of ground. So let me bring on our first guest, which is Dr. Rachel Herlihy. Dr. Herlihy is our state epidemiologist here in Colorado, and she works for the Colorado Department of Public Health and the Environment and is a preventative medicine physician. She's been with CDPHE since 2011 and has been leading our state's COVID-19 surveillance, case investigation, and outbreak response. I'm sure she is probably absolutely exhausted right now, and she's joined us many times for our series, including just a little bit, I think earlier this last spring when we had maybe a little bit of different outlook at the time. Hi, Rachel. How are you doing today? Thank you for being here.
I'm great. Thank you so much for having me back.
Yeah, it's so great to see you. And thanks for all that you do. So like I mentioned, Dr. Herlihy is going to give us a little bit of an update status on what's happening in Colorado. So let me just turn this over to you. Please go ahead.
Great. Thank you. All right. Can you verify that you can see my screen okay?
Looks great.
So thank you so much for letting me join you today. I'd like to provide just a quick update on where Colorado stands right now as far as our case trends, compare a little bit about what we are seeing here in Colorado to the rest of the country, and then briefly talk about Omicron as well, because we know that is going to be bringing us some new challenges in the very near future. All right, so starting here where we normally do with our case trends, this is a figure that shows you Colorado's case trends over time. Each of those gray vertical bars shows you our daily case count, and then the red line is showing you our 7-day moving average trend. Just as a reminder, we look at that 7-day moving average trend as a nice way to smooth out the data and more clearly show us what trends are doing over time. So if you look at that, you'll see that we've had some pretty good news the last couple of weeks here in Colorado. We saw a peak in cases in Colorado in mid-November, and since that time, we've really seen this pretty steady decline. You can see a little bit of a rebound in cases that followed Thanksgiving. Some of that is probably due to underreporting that happens over Thanksgiving. And then perhaps also a little bit of a rebound due to gatherings, unique contacts that occur over the holidays that are not typical for other times of the year. But again, since that bump that we saw following Thanksgiving, this really nice steady decline. And that is in contrast to what we are seeing in the US right now. So throughout the pandemic, different regions of the country have had increasing trends and decreasing trends at different times. We know that the entire country hasn't moved as a single unit as far as waves of COVID-19. And so what we've seen in Colorado in the last couple of weeks is a peak that occurred earlier than what appears to be a new wave of illness that is ramping up across the US right now. This is very similar to what we saw last year. So this exact same time last year, we were in a very similar position where we were seeing cases coming down. Same thing, we saw a peak right around mid to late November in Colorado. So again, very similar situation to what we were in last year. So notably, our numbers are now below US numbers and they are trending down, while we are seeing this trend up in the US overall. This increasing trend in the US overall does precede the arrival of Omicron here. So we know that that is primarily Delta variant cases that are driving that increase we're seeing across the US right now, but probably the increasing steepness in that line over the last few days and probably from here on out is also going to be driven by Omicron. And obviously we have a lot more to learn about the Omicron variant and what that's going to mean for the trajectory of cases here in the US, but in general, we have seen a really steep increase in cases in some European countries that are being driven primarily by Omicron. We now also see New York and New Jersey and several other states where trends are increasing more rapidly. So I think we could unfortunately probably expect the same thing here in Colorado. So the news is looking pretty good right now with numbers going down, but unfortunately, it's quite possible that we're going to see reverse in that trend in the coming days. And the first indicator for me of that is our percent positivity data. If you remember our percent positivity data, this is the type of data that shows us what percentage of our PCR tests are coming back positive in the state. And this is a great leading indicator for us where we can see an early glimpse at what our trends might do over the next couple of days. And unfortunately, just since this weekend, we've seen this rebound in our percent positivity value. So you can see that we're now back up to 6.73%, trending upward. And again, that's in contrast to our case data and also our hospitalization data, which I'll show you in a minute. But I am concerned that our case data will probably catch up with this trend in the next couple of days. All right, moving on to our hospitalization data. The news is still good here, and this is really important for Colorado right now because we are, and I'll show you some additional data on this, we are seeing really, really low numbers of hospital beds available across the state. And so seeing these COVID-19 hospitalizations come down is really important, especially if we're about to face a new wall of infections and hospitalizations due to the Omicron variant. But again, similar to our case trends, we've seen this really steady decline in hospitalizations in the last few weeks here in Colorado. We continue to see that the vast majority of hospitalizations occurring in Colorado are among unvaccinated individuals. So based on the data from Friday, 85% of those currently hospitalized in the state are unvaccinated individuals. This is similar data showing you the risk of hospitalization associated with vaccination. So this is a figure that correlates the association between hospitalization risk, shown on this y-axis, and then the risk of hospitalization based on immunization rates. And so you'll see that we tend to see the highest rates of hospitalization in our counties, and this is for our 15 largest counties, where we have our lowest vaccination rates. And then conversely, we see that our counties that have the highest vaccination rates tend to be the counties where we're seeing the highest vaccination rates tend to be the counties where we're seeing the lowest hospitalization rates. And this is some updated data that we shared just a week or two ago. So this is data that shows you age-adjusted risk of hospitalization in Colorado for individuals that are unvaccinated versus individuals that are fully vaccinated and individuals that are fully vaccinated plus a booster dose. And here we see this really stark difference between the risk of hospitalization in those that are unvaccinated versus those that are vaccinated or have received a booster dose. Overall, the summary statistics here are that people who have received booster doses are 3.3 times less likely to be hospitalized with COVID-19 than vaccinated people. And that's that difference you see down here between the blue and the purple. And then 47.5 times less likely to be hospitalized than unvaccinated people. So really stark difference between that risk of hospitalization for individuals that are unvaccinated versus those that have received boosters. And this is obviously really important for individual level protection, booster doses are, but booster doses are also really important to ensure that we have sufficient hospital capacity here in the state. And so I want to talk just briefly about hospitalization trends in the state and how they relate to the number of hospital beds that are currently available. So this blue figure, this blue trend line shows you, each of those vertical lines shows you COVID-19 hospitalizations on a given day in the state. So you can see our wave of illness that we experienced last fall, and now our current wave with the numbers coming down. And then this orange line is showing you the total number of hospital beds available in the state. And that's total hospital beds, whether that's for COVID-19 or anything else. And so you'll see that when we had our wave of COVID-19 last fall, we certainly saw a significant dip in the number of hospital beds available. But what we see now is very dramatic and very different from what we saw last fall. And a lot of this is being driven by the fact that we have healthcare workers that have left the workforce. And because we have staffing shortages, there's fewer hospital beds available overall. There's also been a lot of deferred care. And so people are needing to be hospitalized for other things. We also see trauma levels back to normal levels. So people are out and about in ways that they weren't a year ago. And so that, again, is also taking up additional hospital beds. So again, a really important time for us to be minimizing the number of hospitalizations that are occurring, whether that's from COVID-19 or anything else. So things that you can do right now certainly are booster doses. We know that booster doses are incredibly important to keep people out of the hospital and preserve our hospital capacity, but also with influenza rising, influenza vaccination as well. And so finally, just a word on Omicron. We obviously still have a lot more to learn about the Omicron variant, but based on the data that we're seeing and the experiences that we're observing in South Africa and European countries, and now in some states on the East Coast, we are seeing clear signs that Omicron variant has increased transmissibility, increased rates of reinfection and vaccine breakthrough infections, though it does look like for severe disease, the vaccine does offer greater protection. We also are seeing much greater protection among individuals that have received booster doses. The data remain mixed on severity. There have been some data out of South Africa suggesting that there's decreased rates of hospitalization, but they also said that there's potentially increased rates of hospitalization among children. A lot of that data is really preliminary, and we're really still trying to have definitive information and understand how that might translate to hospitalization rates here in the US and Colorado. As of last Friday, we had only identified 5 cases so far, but I expect those numbers to increase pretty rapidly from here on out. We have also detected Omicron in multiple wastewater systems throughout the state. So we know it's here. We know the numbers are probably going to increase pretty rapidly from this point out. And that's everything I have for you today.
Thank you, Rachel. Great update. Of course, a little worrisome. One of our audiences was wanting to hopefully see if you could provide some insight into the fact about testing specifically for Omicron and the prediction of it when, how do we test for Omicron right now other than in the lab? And how does that lead into any sort of prediction capabilities that we have?
Yes, so a couple things to say about that. So the way that we confirm an individual is infected with the Omicron variant is through whole genome sequencing of a specimen. And so typically what happens is an individual goes to get a test. For us to be able to do this whole genome sequencing work, it has to be a PCR-based test. So the rapid tests are great, have their own utility, lots of purposes for those tests, but we actually cannot do whole genome sequencing off of those rapid tests. So an individual gets one of those PCR-based tests, and then that test, after it's identified as a positive test result, will go on to have whole genome sequencing done, meaning that we're looking at the entire genome of that particular virus to look for the signature mutations that are associated with the Omicron variant. And so that's how we are definitively identifying the Omicron variant present here in the state. The Omicron variant, similar to the Alpha variant or the UK variant, also has this unique signature profile on PCR, though, that gives us a hint that it might be Omicron. It has something called an S gene target failure, which is basically because of one of the mutations that's present in the S gene, we see that particular gene not amplified during that PCR test. And so you get this dropout type profile that gives us a hint that it's most likely Omicron, but there are other viruses that can cause that same profile. And so again, the definitive result really comes from whole genome sequencing.
Great. Thank you for that. Thank you again for joining us here today. Thanks for all that you're doing in service to the state and for keeping our public informed. I do hope you get a chance to have a restful moment over the holidays. Thank you for being here today.
Thank you so much.
Great to see you, Rachel. All righty. Thanks, everyone. We're going to shift conversation into part 2 of today, which will take us through the next 45 minutes. We're in for another treat because we have another great guest. So as we just saw, while we are definitely not out of this pandemic, we should absolutely be spending some time thinking right now about the next one, as well as the systems and the factors currently in place that have amplified this pandemic in the first place, and what we can maybe do about it. We are joined today. I am joined today. I'm really excited to have Dr. Sandro Galea joining us. He's a physician and epidemiologist. He is the dean and the Robert A. Knox Professor at the Boston University School of Public Health. He is the author of many books, including this new one, The Contagion Next Time, which I highly recommend it if you haven't had a chance. It's out, I think, as of just a month ago, it came out. He's held previous many leadership and academic positions at at Columbia University, University of Michigan, the New York Academy of Medicine. He also worked for Doctors Without Borders. I'm thrilled to have you joining us today. Thank you so much for joining us today, Dr. Galea. How are you doing?
I'm well, thank you, Kristen. Thank you for having me. Thank you for welcoming me to Colorado. I'm just sorry we're not there in person, but it's lovely to be here by Zoom.
That's great. You're in Boston right now, right? Or the Boston area?
Right. Yes, I am.
Is it cold?
It is ridiculously cold today. It is so cold. I cannot warm up.
I will not share what our weather is happening like currently here in the Denver metro area, just to save your peace of mind.
Thank you. I appreciate your kindness.
Well, I have to say, this is a really great book. And I finally had a chance to finish it this weekend. And I actually went through a little bit of an emotional roller coaster on it, right? At times I was feeling absolutely overwhelmed, and then inspired and hopeful, and then back to overwhelmed and, fearful, and then back to inspired and hopeful. I will say by the end I was definitely feeling inspired and hopeful and motivated. So thank you for leaving me on that high note at the end of the book. But it covers a lot of ground, and we will not get to everything that you cover in your book today, but there's a lot of big things that I want to talk about. And it's not necessarily a book about how we failed completely. There's absolutely moments of optimism about things that we have done right currently in this pandemic. But there are lots of points about how we are absolutely falling short, really short in a lot of ways on our shortcomings. So I just want to set the stage here, particularly with the kind of main central theme and one of the main central themes of your book, which is about how we think about health in this country, and that how much attention we actually spend focusing on medicine and healthcare and pharmaceuticals and treatments and so on. Yet really there are so many of these other factors, of course, that shape our life and influence our health in the first place. The social, the racial, the economic factors, those social determinants of health, for those of you who are familiar with that more academic wonky term. So here at the top, just set the stage. Give us a little bit of, how you think about the value of focusing on these more social factors to our health and looking beyond medicine for the answers. Can you just give us that big picture view for us?
Yeah, so what I talk about in the book, and I've talked about in previous writing, is that health and healthcare are not synonymous. And we often mistake them in the public conversation, that when we say health, sometimes we say healthcare, and the two are actually quite different. Healthcare is what we do to make ourselves healthy again when we're already sick. Health is what keeps us healthy to begin with. And the conditions that drive both are very, very different. I mean, what drives healthcare is an investment in doctors and nurses and medicines and hospitals. What drives health is investments in the food we eat, the air we breathe, the water we drink, whether we have opportunities to exercise, whether we're free from violence, whether everybody has a livable wage, whether or not there is gender equity. Those are the forces that drive health. Most scientists in the space, population health scientists, agree that the forces that drive health probably matter for about 80% of our health. Healthcare matters only for about 10 to 20% of our health. But having said that, our national investment is almost all on healthcare, really by about 99 to 1, 90% is all on healthcare, on medicines and doctors, much less on the other forces, despite the fact that the other forces matter a lot more. And we saw this in COVID. So just to bring this to COVID, I started the book by commenting on the fact that COVID has been a success on two key fronts. Number one is healthcare. Our healthcare system has actually really done a very good job of treating patients with COVID. When COVID hit, it was a brand new disease. We had never heard of it. People were coming to hospital, and about 1 in 4 people were dying from COVID once they got to the hospital. In about 2 months' time, we had lowered that number dramatically to about 1 in 20. And that was our healthcare system adapting, our nurses, our doctors, our clinicians getting better at treating COVID. That's an extraordinary success of our healthcare system. And of course, the other success is vaccines. Vaccines are a triumph of biomedicine. I mean, we saw Dr. Herlihy's slides showing like this extraordinary difference between people who are not vaccinated and people who are vaccinated. I mean, that is really tremendous. And it reflects decades of investment. mRNA vaccines, which are the ones it's clear now that they're the ones who are much more effective against the COVID. And it was sort of clear from the beginning, but now it's much clearer. They sort of came out of nowhere. But in fact, we had been investing in mRNA vaccines for about 20 years. So healthcare and the vaccines represent this triumph of our investment. We invest in hospitals, we invest in nurses, we invest in doctors, we invest in clinical treatment, and we do well at it. We invest in vaccine technology and we do well at it. But at the same time, I don't think anybody in the audience would say that we've done well in COVID. I mean, COVID, I think we see as a failure. 800,000 Americans have died, about 5 million people around the world have died. But focusing on this country, why do we see it as a failure? We see it as a failure because a lot of other things failed. And those other things are the conditions that can make us healthy. And we were, in many ways, sitting ducks for a bad pandemic. And I'll just use one concrete example. We, as a country, we're about 30% of the country, probably more, close to a quarter, a little bit more than that, obese. And we know that COVID affects people more severely who have underlying illnesses of obesity, heart disease, things like that. Well, when you have an unhealthy country to begin with, COVID is simply exploiting that unhealthiness and has become much more severe in this country than it has in comparable countries that actually have less underlying morbidity. So that was our failure to keep ourselves healthy before COVID is then exploited by a new disease to make us really quite a bit sicker. And there are many other things which I talk about in the book, which we can talk about, all of which really predate COVID. They were how we did not structure our society right. And as a result, we became vulnerable. And these vulnerabilities are exactly what COVID exploited.
Can you put this into the context of the US and how we compare to other higher income countries? Both, we had an audience member submit a question in advance asking specifically about how our healthcare compares, but I would also frame our health compared to other high income countries. So how does that look?
Sure. Yeah. And I think in terms of the comparison, in terms of how our healthcare compares, let me start from there. Once you are in our healthcare system, because there's this caveat that a lot of people still do not have access to quality care. Once you're in our healthcare system does very well for you. That's healthcare. But in terms of health, we spend about 40% more on our health than any other country in the world. This is per capita. And at the same time, we live shorter and sicker lives than all other high-income countries. So we have about 5 years less life expectancy than other high-income countries. That's a lot. 5 years is a lot of time. And I would challenge the audience to say, how many of you agreed to live 5 years less than other high-income countries? And I actually bet that none of us really agreed to that. But that's essentially the situation we have. So we live shorter lives and we have more sickness during our lives, which means we have more heart disease, we have more lung disease, we have more cancer during our lives. And all of that is fundamentally linked to how we live and the conditions in which we live. Now, it's a bit of a paradox if you think about it, that we are willing to invest more in health, as I said, 40% more than all other countries, but our health is worse. Our health is worse and we live shorter lives. And in fact, I sometimes challenge audiences to say, name one other sector where that we spend more and get less than all other countries. It's actually very hard to think about. It's hard to think about. Like, if I were to say that these smartphones cost 40% more if you buy them here than, let's say, other high-income countries, but they hold less data, they're slower, and their resolution is blurrier. We probably wouldn't buy as many smartphones, right? But that's what we accept on health. And it's a funny thing that we accept it. And I think we accept it because we have a misconception of what health is. And we've had that for decades.
And that misconception is kind of, we can unpack that a little bit because I know there's lots of layers to it. But part of it, I think, is this focus on the treatment side, right? This healthcare side, this medicine side. So when you're talking about investments, right, and the sheer amount that we do currently invest in healthcare and medicine and pharmaceuticals, et cetera, that side of the equation, versus the amount that we focus in on the social factors that lead to this in an unhealthy population in the first place. This is really complex, right? And so how do you focus on that complexity of investment to this other approach? How would you shift that approach? Is it a shift in thinking, a shift in policy needs to be taking place, all of the above?
Yeah, I think the answer is yes, because it is all of the above. But I actually quite like, Christiane, I quite like how you said a shift in thinking, a shift in policy. And I actually think that's the sequence, because policy shifts when our thinking shifts. And the book I wrote before this one was called Well, and the subtitle was How We Talk About Health. So it really was about talking differently about health. And I've become convinced that our policymakers fundamentally reflect the public conversation. So the metaphor I use is, as long as at the kitchen tables in every country, every kitchen table in the country, when people are talking around the kitchen table and they say, well, what causes health? If we all keep saying our doctor causes health, we're going to keep investing only in doctors and medicines. If we say, actually, what causes health is the fact that I'm living in a stable, clean house. What causes health is that I'm not at risk of dying if I walk out in my neighborhood. What causes health is that I have clean air to breathe and clean water to drink. Once we start saying that, our policies will start reflecting that priority. So I really think that what we should be talking about health, which is my previous book, is ultimately talking about health rather than healthcare. And really, the pandemic revealed the limitations of us continuing to think about health as healthcare rather than thinking about health as health.
Can you talk a little bit about some of those limitations? And I'm sure some of this is, and I want you to take that too into the idea of the public opinion and how that shapes politics and a little bit in the policy part. So, but where have we seen that happen with the pandemic specifically?
So let's take one concrete example, which I talk about in the book, about one feature of the pandemic. So one feature of the pandemic has been, I think everybody who's listening to this by now knows that the pandemic has resulted in racial disparities. So Black Americans died about twice the rate of white Americans during the pandemic. So let's just take that example. So what explains that? I think most people sort of who read and are engaged in this conversation by now recognize that, but I'm not sure we've spent enough time pausing and saying, why is it? Well, there are two reasons for that. The first reason is economic structure. So let me explain that. When the pandemic first hit in March of 2020, one of the first responses to it was essentially lockdown, essentially getting everybody to stay home. But of course, getting everybody to stay home, you can think of the word everybody between air quotes, because it really wasn't everybody. It was actually only a minority of people who could stay home. And that minority were the people who had the higher wage jobs and jobs where you could stay home. Well, those higher wage jobs are disproportionately majority group jobs, and Black Americans are disproportionately more in essential jobs. And those essential jobs, of course, kept going to work. So at the beginning of the pandemic and going on for months and months in the pandemic, Black Americans, low-wage earning Americans were more exposed to the virus, as a result had higher rates of infection. That's reason A. Reason B is, we know, and I've alluded to this already, that the biggest risk factor for having a severe infection versus just having a mild infection is having underlying health conditions, underlying heart disease, underlying hypertension, underlying diabetes. Well, the people who have underlying heart disease, hypertension, diabetes are people who have been disadvantaged already, people in low-wage jobs, people with fewer assets, less wealth, and those groups are disproportionately minority groups, disproportionately Black American groups. So Black Americans more likely to actually acquire the infection, and when they have the infection, more likely for it to be severe because of underlying conditions. And those two reasons result in the 2-to-1 difference in mortality between Black Americans and white Americans. And those two reasons have nothing to do with medicine. They have nothing to do with receiving poor care. There's very little evidence that actually there's differential poor care by races in time of COVID once people were in hospital. These differences were all before the hospital. They had everything to do with economic structures and with underlying conditions that come from decades and centuries, really, of different groups being treated differently and having different disease burden.
Yeah, thank you. Let's stick on racism and racial inequities, which you do spend some time on in your book. You know, both the fact, I think you had drawn connections, of course, like you just did there, between racism and the pandemic, as well as parallels between how we've inadequately addressed both in this country. And you know, you start to mention about some of the underlying health challenges, whether it's obesity or heart disease. But there are other disease systems in place, right? Including redlined neighborhoods historically, right? That there's these really deep systemic challenges of racism in our country. And I think wasn't there an example in your book specifically in the Boston area, right? Where you were looking at where there's like red hot zones associated with COVID-19 that also have historically been redlined neighborhoods and cities. Could you talk a little bit about both these parallels and these connections?
Yeah, so let's talk about redlining. Redlining is a concrete example which I use in the book because I think it helps concretize these ideas. So you have African Americans in the country being disenfranchised for centuries, culminating obviously in the institution of slavery. Then slavery goes down about 150 years ago and gives way to Jim Crow laws. Now you start in the 20th century, so in the 1910s, 1920s, the American government says it'll be good for the country if more people own homes. It's probably a good idea. So the Homeowners Loan Corporation is established. The Homeowners Loan Corporation's function was to encourage banks to lend money to people for mortgages so that people can own homes. Now, how did the Homeowners Loan Corporation go about doing its job? It would take maps of cities and it would color them in: green for areas where banks were encouraged, safe bets for mortgage lending, yellow for maybe, and red for don't lend money here. Well, what were the areas that they were shading in red? They were areas where African Americans disproportionately lived. That's the term redlining, but the term redlining actually was red pen on maps. So in 1920, 1930, as a result, white Americans start owning homes at a high rate. Black Americans own home at a much lower rate, because remember, banks are not lending to Black Americans. So now fast forward 70, 80 years. Well, white Americans have now built assets over generations. They have more wealth, and they have more wealth, which they're able to then put into better homes. Black Americans have less wealth, and they're living in worse homes. Now come to a pandemic, where protecting ourselves from pandemic is predicated on two things: keeping ourselves away from each other and having better jobs that allow us to sequester from other people. Well, if you haven't invested, you don't have wealth, you don't have assets, and you're living in homes which are smaller, very closer to each other, A, you're coming close to each other more, and B, all of a sudden you're not in jobs which afford you the luxury of working from home. And all of that really is connecting dots over decades and centuries to practices like redlining, which really emerged from the Jim Crow era, which really emerged from institutions like slavery, which really emerged from centuries of institutionalized racism. So and that's just one example of that. And I think in this country, we have such a contentious relationship with issues of things like systemic and institutional racism. And I tried in the book to look at it dispassionately as an epidemiologist. I'm trained as an epidemiologist to say these are clearly forces where these forces translate directly into the burden of disease that we saw with the pandemic. So therefore, when a next pandemic hits, hence the title, we should make sure that we fix these forces so that we do not have these same outcomes with the next pandemic. And that's really what I try to do in the book.
Yeah, and I really like this book, Sandro. So we're gonna probably veer around here a little bit too, but I think it's let's just fixing some of these forces, some of these underlying factors, right? So that we are better prepared for a future pandemic, right? Because I think you talk a little bit about this in the book, but there will be another pandemic. Mm-hmm. And who it hits, right? We like, you don't know that impact on who is going to be impacted by the next pandemic. And so kind of this underlying idea of, in essence, of a common good or public health, as that common good. Could you go there? Because I think there's a lot there that we should talk about.
Yeah, well, maybe I'll use a metaphor which I use in the book to explain it, which is, let's talk about firefighting. So firefighting has been around for a couple of thousand years. Initially, the first fire departments came from the Roman Empire because the Romans were building all these cities made of wood, and every once in a while things would burn down. They realized, we probably should have some system where people can come around to put out fires. Firefighting really was largely unchanged for about 2,000 years, which is a bunch of people sitting around, and when there's a fire, they get called off to put the fire out. About 50 years ago, in the US, there was an influential fire chief who said, well, wouldn't it be better if we also played a role in preventing fires? So fire departments started playing a role in helping set building fire codes and helping train people for what to do when there are fires, helping make sure that in industrial areas and schools, people knew what to do with fires. In the past 50 years, we have dropped the number of fires in this country by half. Now, we still need fire departments because we all realize that if there's a blaze, we actually need fire department to help put them out. But we've invested in preventing fires, and surely we can all agree that actually our cities, our rural areas are better because we have fewer fires. So that's element A. That's where generating health rather than focusing only on the healthcare, the cure, which is what the firefighters do when they rush to put out fire, is a better approach. Now, metaphor B is fire departments reflect the fact that fires are, and the threat of fire is a public concern. It's a common concern. And that you don't really want to own your own fire department. I don't really want to own my fire department. If we're living in the same town, I want to know that we're in a community where there are enough fire departments that can actually come to your house or my house if we need it. That's what thinking of fire and fire prevention as a public good means. It means recognizing that this is something that is best shared. And that's how we need to think about health. Now, if we think about health that way, it moves us away from thinking about that I can buy health or that you can buy health. Because really what I can buy is cure. And what you can buy is cure. But when you realize that my health and your health are generated by the world around us, the conditions of where we live, where we work, where we play, then you realize that actually it's not really about you and me buying it. It's about us buying it for each other. You know, one other metaphor, just for a moment, is public parks. It's public parks. Imagine, you know, we're not in the same town and there's a public park in the middle of town. And I first started using this metaphor in Manhattan, because I was in New York before I came to Boston. You know, you have Central Park in New York. It's a beautiful park, right? It's a public park. And you know, there are a lot of rich people in New York. And supposing everybody said, I don't really want to share this park with you. So what I want is I want my piece of the park. Well, you go from this beautiful green park that everybody shares to everybody owning a postage stamp sized piece of park. Now, it may be yours, but what exactly are you going to do with a little square of green grass? Not very much at all, right? So firefighting, public parks, and health are examples of things that we should want to be public goods. They should be things that we want to invest in collectively so that then we treat them collectively. Now, I think the misunderstanding has been over time that that little piece of grass, metaphorically, my health, is good enough. That you know what, at the end of the day, let me own that. I don't care about your piece of grass. But what the pandemic has taught us is this: if you have COVID, I'm at greater risk of COVID. If everyone in the audience has COVID, you and I are both at greater risk of COVID. So it really has shown us how we're all interconnected. And that, I think, makes the case strongly for why we should treat health as a public good.
And you started to touch on this, but why don't we currently treat health as a public good? I know this is a big philosophical question, probably, you know, multiple theses in there, but why? Why do we currently not treat it as a public good?
Yeah, I think it depends on one's perspective on this, but there have been real historical efforts to move our thinking away from seeing health as a public good. A lot of that was actually was the result of organized efforts by medicine. So medicine, there's an excellent book if anybody's interested in this, recognizing this is co-sponsored by the library, which is called The Social Transformation of American Medicine by Starr. And that book really, and they won the Pulitzer Prize, it did a terrific job of actually showing how medicine professionalized, and it became in the interest of medicine to promote the notion that medicine was what mattered above all in the context of health. Now, I'm not trying to ascribe to organized medicine malintent. I think medicine was protecting its own interest. But that, coupled with a real shift in this country at the early 80s towards an ascendant political view of individual ownership, resulted in us attributing those notions of individual ownership to our health as well. And while the notions of, sometimes when I speak like this, somebody will challenge me saying, you're speaking against capitalism. I'm saying nothing against capitalism. Actually, as an immigrant to this country, I actually have deep respect for a market-driven economy. All I'm simply saying is that some things lend themselves to market-driven economy and shared public goods much less so. It is much harder to buy the public park. It is much harder to buy fire departments, much harder to buy health, when you realize that the majority of health is generated by the world around us.
Yeah. The personal responsibility, culpability, right, that's associated with individual health, right? I definitely think that's a strong narrative I've seen, that, you know, that we're individually responsible for our own public health, when really it is a lot of these other factors under play. So that, I mean, that there's some biases that go into play there. You're talking to someone, we'd love to talk about this, like the values, the biases, yes, our human nature, you know, so this is where a lot of our conversation is. While we're at the Institute for Science and Policy, it's this middle part stuff that we really like to unpack. So talk to me a little bit about biases. Yeah.
Well, let's talk about one of the narratives and that one often hears about freedom. So one often hears about, well, in America we value our freedom, to which my answer is absolutely, absolutely. And the fact that millions of immigrants come to this country every year shows how powerful that notion of freedom is. And this is nothing against freedom, but we need to be organized in how we think about freedom. So let's think about freedom. There are different kinds of freedom. There's a freedom to and a freedom from. And we want to have freedom to do things. but we also want freedom from things. So what are the kind of things we want freedom from? Well, we want freedom from unnecessary risk of death. We want freedom from sort of walking out in the street and running the high risk of being run over by a car. We want freedom from running out in the street and having a high risk of being shot down. And we as a society accept restrictions on some of our freedoms too, to make sure we protect our freedoms from. So we make sure that people do not drive while they're under the influence of alcohol, right? That is a restriction of a freedom too. One could say, I want a freedom to drive under the influence of alcohol. Yes, but that freedom intervenes with your freedom not to die from somebody running you over in a car, right? So we make this balance all the time in society. So this notion that there's anything inimical to the idea of freedom here is simply wrong. These are all freedoms. It's freedom from, and freedom to, and we want to balance them and maximize them so that we can actually be as free as can be, to be as healthy as can be for as long as can be. And we don't really have this conversation. Like, this conversation about health is not even in a public space. And it just shows how far we are from wrapping our brain around the determination of health being a shared good, being something that comes from the world around us, not just from us as individuals.
Yeah, and we're doing a little bit of that right now, right, Dr. Galea? So thank you for that. We're going to continue on with this conversation. I want to pull in an audience question and then maybe switch some gears here. But Michael asked, how do you raise the life experiences of those less fortunate without decreasing the experiences of those more fortunate? And you were talking a little bit about that, but share a few more thoughts, please.
Yeah, so a couple of thoughts on that. Number one is that the question correctly implies that in our thinking on this, we often think of it as a zero-sum game, that you need to lower one group to raise another group. But none of this actually is predicated on that. This is all predicated on the notion of rethinking what we spend our money on and recognizing, for example, that investment in early childhood education yields $5 for every dollar spent. How so? In preventing teen violence, preventing unwanted pregnancy, and people having better economic attainment, then having higher income, paying more taxes. And there are studies that show this. So actually investing in early childhood education to lift all boats, to elevate everybody, has a net return on investment for society, which then returns more resources to society into other things we can invest. So right now, we are undercutting ourselves. We are undercutting ourselves by not investing in the forces that generate health, that keep us all healthy. And of course, what the pandemic teaches us is that the line between those less fortunate or more fortunate is pretty blurry, because if those less fortunate, to use that term, are carrying a high burden of COVID, it makes it much harder for those who are more fortunate to avoid getting COVID or to get on with their lives. And the history of the world amply shows that we do not tolerate inequities, large inequities, for a very long time. And the history of the world is constantly a history of societies that get prosperous, have wide gaps, and then collapse on themselves. Because at the end of the day, there is only so many of those gaps we can tolerate, because ultimately the gaps bring us all down. And I think at a very pragmatic level, we need to recognize that. I particularly admired one of the quarterly shareholder letters by Jamie Dimon, who is the CEO of the largest bank in the country, JP Morgan. He actually made this exact point I'm making. So if anybody has heard me make that last point and thought, there he goes being a socialist, well, it's hard to argue that Jamie Dimon is anything but a card-carrying capitalist. So all to say that I think this is not a socialist or capitalist argument. It's actually a common sense argument grounded both in deep respect for shared human values and for our shared humanity, and also, frankly, from a very pragmatic understanding of how human beings work, and from an understanding that we need to make sure that the gaps that distinguish the haves and have-nots are controllable, and that fundamentally do not result in the kind of wide breakages that result in tearing us apart.
Thank you for that. You're absolutely right? There are these common values, this common humanity, right, that we can start these conversations from and try to build from, no matter, various different beliefs and stuff that we bring to the conversation. But you hit on it right there, and we can't escape not talking about some of the politics and some of the division, that we both I at times feel very, frustrated and
Yeah.
disheartened about to see these partisan divides happening in our country and wanting to bridge some of that. And those feelings that we just see, and of course, are amplified by the media. And I want to talk about the media, but I want to talk a little bit about some of the politics and the partisan nature thus far, and how some of that, how do you view that as both in the current pandemic, as it's hindered and hampered both our response and where we got here, and how does that look like for the future, right? I think there's a lot of fear about our state of democracy right now. So how do we approach that right now? Your reflection to be better prepared for the future.
Yeah, and I actually don't think that I can even answer that about the politics and divide without folding the media into it. And let me explain. So the 9/11 terrorist attacks 20 years ago was the first mass trauma that the country went through in the era of 24/7 cable news. And if you think back to that time, to 20 years ago, there was a bit of conversation, actually, a fair bit of conversation about how we experienced that event and how we experienced things that happened afterwards was all refracted to this era of 24/7 news, which changed the public narrative around it. Fast forward 20 years to COVID. Why did I mention that? Because COVID was the first national trauma experienced where the dominant form of public square was social media. Now, social media is a very particular form of communication. Social media is a form of communication that's an algorithmically driven form of communication that is designed to elevate the confrontational, the divisive, the emotive, right? And to downplay things that are more cool-headed and calm and ambivalent. So in that space, a pandemic hits in the last year of a president's tenure, where the president sees the event through the lens of his re-election chances. And of course, the opponent sees the event through the lens of the opponent's chance of getting elected. And what happened, in my estimation, is then that resulted in a cleavage where positions about the virus hardened very quickly to being essentially, you are for or against the president's re-election. And camps quickly formed, as they do in partisan divides always, but these partisan divides pervaded everything that we were doing about thinking through the virus. And all of a sudden, it became impossible to shift those perspectives. If you were in the president's re-election camp, you were like, well, you're against masking and you're against any effort to do anything about the virus. If you're in the other candidates' camp, all of a sudden you're for every single public health effort, and anything that we fall short of doing that is unacceptable. And of course, both camps are wrong, because this is not an issue of camps. This is an issue of complicated, nuanced, changing reality. And we should have had the wisdom to say, it's not red or blue. This is the reality on this is ultimately purple, that ultimately lockdowns are not a solution because they hamper the economy and end up hurting the very people that they're trying to hurt, that they're trying to help. Similarly, saying that the virus doesn't exist and that things which are evidence-based, like wearing masks in public crowded indoor spaces when there are no vaccines, is silly, because actually it flies in the face of both logic and science. And so all of this, of course, happened and then is amplified by social media, which, go back to where I started, is designed to amplify and elevate the voices of disputation and emotion. And all of a sudden, the entire story of the pandemic is told through these two extremes, this red extreme and this blue extreme. And the majority of us in the middle, and I do think it's the majority of us in the middle, majority of us who really are able to take a step back and be reasonable and measured and say, there's pros to this, there's cons to this, we should be balancing the pros and cons, and realize that how to deal with the pandemic is one long exercise in trade-offs, an exercise in trade-offs that should weave its way into our reality. And we're willing to entertain that kind of adult, mature discussion. That has never happened. I would challenge anybody in the audience to point to where in the national discourse we have said dealing with this pandemic is an exercise in trade-offs, and we have to be mature enough to realize that we want to give up some things to achieve others. That sentence has not entered the public space. And that's really disappointing. We should be disappointed by it. We should be disappointed by the fact that partisanship divides us in such a way that it has become impossible for an elected politician to say that sentence. Because fundamentally, that's exactly what we want elected politicians to be able to say, right? We elect people to political office specifically so they can manage the difficult trade-offs that we need as a society to move us forward. And in a time, the past 20 months, 22 months, where we've needed that most, that has failed because we have carved these positions etched in red and blue stone on either side of the pandemic divide. And that has been terrible for us.
Yeah, well said. And it goes a little bit, you touched on this, but speaking about trade-offs and speaking about where we get things wrong, right? And being able to you spend a lot of time talking about humility towards the end of the book, which I really enjoyed. But the idea that we can be wrong. And so I'm going to move this a little bit into the sciencey realm for us, right? And how we talk about science and the narratives and how that can get politicized at times.
Yes.
Because, but we need to have that humility about there are trade-offs, there's tough decisions, and we do get things wrong sometimes, right?
Yes, absolutely. And if I may, sorry, I didn't mean to cut you off, but
Please,
one of the phrases that annoyed me most during the pandemic is the call and cry, follow the science. And let me explain. I actually have written about this in Scientific American workplace. I was glad they published it. The term follow the science suggests that science gives a dispositive black and white answer about the right thing to do. And that's foolish. Science can show us the evidence of what pushes viral transmission. Science can say to us, if we did X, we're going to have these many fewer cases. If we did Y, we're going to have fewer cases. But the decisions about what we should do are fundamentally political decisions, and that's what they should be. Science is an input, not a determining factor. But the very fact that follow the science became a bumper sticker just shows how polarized we became, because it felt like if you're blue, you believe in science. If you're red, you don't believe in science. Well, I have many red friends who actually believe in science, and I have many blue friends who actually are more skeptical of science. So it really, follow the science is nonsense. Of course we should follow the science. Like, why should that even be subject of discussion? But the science never tells us what the right thing to do is. The right thing to do is a political decision that's based on trade-offs. One illustration which I use in the book is the example of speed limits. So the science is very clear. The lower the speed limit, the fewer people die on the roads. So if you have a speed limit of 35, fewer people die. And if you have 45, then you have 50, you have 55, you have 65. But we don't have speed limit of 25 in all our roads. We have speed limits of 45, 55, 65, depending on the road. So the science is the science, but we make decisions based on many other factors, including how quickly we want to let people to get from A to B. And we accept the fact that that has a cost. That's what politics does. Politics takes science, interprets it through our other lens of other values, and comes up with decisions. And that process, that very simple process, science gives us data, politics integrates the data with other values that inform what we do, and comes up with decisions, completely broke down during COVID.
And I would offer too, the rate of dealing with uncertainty and unknowns, we as a society, particularly in this hyper-connected, information-saturated world, don't do a good job. We are looking for answers. We are looking for these solutions, right? And so the framing of those trade-offs, the framing of science as a process, the science that sits in the idea of uncertainty and unknown, right? That is some of the roots of why science evolves and what its purpose is for, is to try to explore those avenues. But that's really hard, right? When we're faced with a crisis that is a pandemic and people are fearful and there's emotions and there's politics and there's all this other stuff coming to play, where people want to be told, right, what they can and shouldn't do. And yet at the time, I think there's a lack of us then communicating, this may change, and here's why this may change. What do you think, from the scientific side of the house, we maybe didn't do very well there? Or maybe we did really well. Both. Let's do both good and bad.
Well, and this is why I talk about humility in the book. I mean, I talk about humility as an antidote to what I call epistemic arrogance, which is the arrogance of knowledge, which is the arrogance that says that doesn't have the humility to realize what we don't know and how much we don't know it. And I think we did this poorly in that, for example, the prime example, of course, is modeling. Every modeler knows that our infectious disease modeling is based on our assumptions. And all sorts of models were built early in the pandemic. They were built on all sorts of assumptions that turned out to be wrong. And the modelers know that there is this limitation. But this is where the science intersected with the media, intersected with the politics. So the scientists do their science, and smart scientists know that there are limitations. But the results are summarized on social media, which really capture only the top level heading that says, paper says X, right? Social media gangs up and elevates it or doesn't elevate it. It's reflected in the mainstream media. The politicians are then under pressure to act. And because of the divides that did not create the political space to have nuanced conversations, politicians end up acting. So if you think of it this way, no one actor here is being malevolent. It's not that the scientists are being malevolent. Social media is what it is. Social media is a set of algorithms, and we should just have recognized as what it is. And the politicians are acting based on the pressures they're under. But with no one being necessarily malevolent in this cycle, it results in a holy mess. It results in a mess because the doubt that we should have about the science, the humility we should have about what we don't know, the uncertainty we should have about the science is not communicated, and action is then being dictated by a sense of false certitude, which takes us down these cul-de-sacs. And then we realize, oh, we've kept kids out of school for a year. And keeping kids out of school for a year means that we have delayed the social, developmental, economic achievement milestones for a whole generation of kids. And that is going to hurt kids of this generation throughout their life course. And that is a price that I think we should not have been willing to pay. And had we had the conversation about what's the price that we're willing to pay or not willing to pay, I bet the majority of us would have said it's not a price we're willing to pay. But it sort of became something that just happened as the confluence of science amplified through social media with a clear set of directives that then intersect with this political mishmash. All of a sudden, before we knew it, kids were out of school for a year.
Yeah. I feel like we need long pauses after you say something so we can just ingest a little bit more, I think. But we are coming up on our time. I want to ask you a little bit about, momentum or lack thereof right now. It's not fully 2 years here, but in essence, closer to getting to 2 years into this pandemic. And I think that we need momentum in essence to learn, to figure out, to be better prepared for the next time. I mean, what do we need to do right now to not lose some of that momentum so that we can continue to figure out these large system changes that you're pointing to that we need to work on?
Yeah, in some respects, I wrote this book to make sure it's there as part of this momentum. I was expecting that, some people said, well, you wrote this book, do you think the pandemic is going to be over? Which I don't know. I didn't know the pandemic was going to be over, but the book is sort of irrelevant whether the pandemic's over or not. The book is part of saying we should be learning and we should be reflecting, and it's time for us to start learning. It's not too soon for us to start learning. And I think there are going to be a lot of books written about the pandemic appropriately. I think a lot of them are going to be about vaccines, about health system infrastructure, about making sure we have enough ventilators, about therapeutics, and all that's important. But I don't want in that conversation for us to lose sight of these more fundamental forces that I'm talking about. So I think the momentum is maintained by shows like yours. And Kristen, I'm grateful to you for having me on, and to Dr. Samet for introducing us, because I think this has been such a momentous period in all our lives that the tragedy, this event is a tragedy that nothing will really redeem it, but it'll become a worse tragedy if we don't learn from it. So I think what we should be doing is have these conversations so that we shift what it is we talk about when we talk about health, so that we have a better world prepared for the next time a pandemic hits. And there will be another pandemic. The question is not a matter of if, the question is a matter of when.
Give me one word here to close out some of your thoughts about how you're feeling and thinking about the year ahead. I'm talking about 2022.
One word would be hope. I actually am hopeful about the year ahead. And we heard from Dr. Herlihy about the worries about Omicron. And I think there's plenty of things to be anxious about, but I am seeing it already. I'm seeing a lot of conversations. For example, you've seen several people now sort of been very public about, okay, well, closing schools should not be part of our solution set. Like that, just that we have learned from it. And you've seen more and more people being able to say, look, there might be more Omicron, more virus, but it's actually less severe disease. And we should make sure that if people are vaccinated and tested negative, that they can get on with their lives and participate in group gatherings. That gives me hope that we are learning. So 2022, I'm leaning into hope.
I appreciate that. I'm also a hopeful person too, and it's nice when I can get it from someone else who's also feeling a little hopeful, because it's been a long couple of years, and I hope everyone here has left this conversation, will leave this conversation today, both with some hope, with some inspiration, as well as just some motivation to really think deeply about these complex systems. They are very complex. They are very nuanced. There's trade-offs. This was such a great conversation, Dr. Galea. Thank you for joining me today. I really enjoyed this.
Thank you, Kristen. I really enjoyed it as well. And thank you for having these conversations.
Great. Thank you to our audience for joining us today. I hope you have a really good rest of the year and new year ahead for you all. Stay tuned about when we come back and what that looks like for us. Stay safe, stay healthy, and hopefully you find a couple moments of joy. Nicole dropped some links in there if you're interested to find out where the series is and all the other videos, as well as a link to Dr. Galea's book, The Contagion Next Time. Check that out in the chat. Everyone stay safe and well and have a great new year. Thank you for being here today, Dr. Galea.